Sir, good evening, sir.
Good evening.
Good evening, Dr. Sandeep. Good evening.
Good evening, Dr. Varun. So,
Good evening. Hi, Secretariat. Can you hear me and see me clearly, please?
Yes, sir. Yes, sir. Perfect. Fine,
Right,
sir.
thank you so much. My apologies for the delay, 2-3 minutes. I'm so sorry. And fold and hands apologies.
No problem. 1-2
Thank you so
minutes.
much.
No
Yeah.
problem.
Thank you so much, Dr. Goel, for acknowledging my apology. I can see that our esteemed speakers have joined in, and we have panelists and also we have attendees. So taking just 30 seconds for some housekeeping, and then we start, please. Thank you.
yes, sure.
So good evening and a very warm welcome to all the esteemed attendees, panelists, and highly esteemed speakers of today's evening on this ENOCH platform of Association of Occupational Health, Environmental Occupational Health Delhi, which is Delhi branch of Indian Association of Occupational Health. I am Dr. Pawan K. Gupta, part of the AUHD as executive body member and web secretary for Indian Association of Occupational Health, the parent body, and also secretary for Haryana branch of Indian Association of Occupational Health. Very warm welcome this fine evening. We are once again gathered to deliberate and learn more, as we have been doing since past 2 years. We have conducted more than 110 webinars approximately, rather 120 webinars on the platform. And it has been only possible because of the esteemed speakers like you, who have agreed to spare their time and contribute for the cause of making the awareness spread across and wide on various topics. Just like today's topic, current perspectives of gynecological malignancies, very pertinent, very important. And at times these are the burning issues, because cancer definitely is one of the most talked about agenda in any healthcare setting. I can see that I'm very well joined by our Honorary Secretary of IUH, Dr. Sandeep Sharma. Very good evening, sir. And a very warm welcome.
Good evening.
Thank you so much. And then we have Dr. Goel with us. Thank you so much, Dr. Goel, for spending your time. Really appreciate your kind gesture.
Yes, good evening all, and it's pleasure of mine, to join all. So I thank all of you for joining today. And
thank you so much, Dr. Goel. And then we'll be joined by Dr. Swami and Dr. Shekhar and Dr. Chaudhary.
Thank you, sir. Thank you. Good evening.
Pleasure. Very good evening, Dr. Swami. Such a pleasure. It's always good to see the face, faces with the names connected. It's always great. So without taking any further minute, I have mentioned that this is the topic that we are going to deliberate. I will be handing over this e-platform to our Honorary Secretary IOH and also Honorary Secretary of Delhi branch of IOH as well, Dr. Sandeep Sharma, for further deliberation. And before that, just wanted to mention that this is a body 3,000 plus member strong body of occupational health physicians of the country, who are probably forming the backbone of the force which is working for all Maharatna, Navratna, Mini Ratna, private giants of India, who are probably contributing significantly for India's economy. All the corporate groups. So these are the physicians and doctors who are keeping this field force healthy. They are taking care of them so that we keep growing. And Dr. Sharma is the torchbearer as part of General Manager for Indian Oil Corporation Health, Safety and Environment. And we are privileged and honored that he has been continually contributing for this cause. So with those words, and I would proceed towards introduction of today's speakers and also introduction of the moderator of this event today. So after Dr. Sandeep Sharma, definitely will be taking it up first, then followed by Dr. Varun Goyal, who is the consultant medical oncology at Rajiv Gandhi Center, Rajiv Gandhi Cancer Institute and Research Center, Delhi. Then Dr. Shiv Shankara Swami. Dr. Swami, a very warm welcome. You are also part of the same institute, and we are privileged to have you this evening. And then Dr. Shekhar from Rajiv Gandhi Cancer Institute itself, and then Dr. Kumaradeep Dutt Chaudhary, and he's the senior consultant and unit head, Action Cancer Hospital, and he will be moderating this session as well. So thank you so much, Dr. Chaudhary, for your kind gesture of accepting this and also taking the session forward. I really appreciate your gesture. With those words, welcoming you all and everyone once again. And this is a platform where we record this entire session. We put it on our YouTube channels and social media platforms. So the audience is very vast and wide. It's a global platform, and we have that bank with us, all thanks to speakers and faculties like you who have contributed. Thank you so much. And with that, I hand over this platform to Dr. Sandeep Sharma, please.
Thank you, Dr. Pawan, for the nice introduction of this platform. And let me thank all our learned speakers for sparing the valuable time for this particular session. And to set the stage, this topic which was allotted to me, I thought I should do some justice to this topic, because in addition to the malignancy, there are a lot of issues which are to be taken care in case of women health. And for this, I've taken the references from WHO, because WHO is the key nodal body which is taking care of the health of the people across the globe, and how important they feel that women health is important. And for this, I got a small presentation. I'm just sharing this with you all. Can you see it, Dr. Pawan, now?
Yes, sir. Slides are visible.
Slides are visible. Okay. So
yeah, it's quite visible. Yeah.
Yeah. So the topic which is allocated to me is what are the current challenges in case of women healthcare in India and across the globe. So why is women's health is so important? Women health is important because women, they represent the cornerstone of a family's overall health, ensuring they have access to the quality care. Also, it can lead to improved health for the children and for the family. So they are the center stone of the health of the family, of the community. So it is very much important that we should take care of the women's health, and the health of the families and communities are no doubt tied to the health of the women. As per WHO, we need to focus on 3 critical issues. And these 3 critical issues, as per WHO, is look at the women's health in totality and not just focus on the sexual and the reproductive health. And we need to understand and address the gender gap in access and care of the treatment. And this especially is more important after this COVID pandemic. We are going through COVID pandemic for last more than 2 years now. And women health is the most suffered thing which has been of concern to every one of us. And we have seen that many of the females in our families, in our society, they just ignored their health. And it is our responsibility that total health is extended to them. And we need to understand and address the gender gap in the access to care and treatment, because females are a lot of them, they are confined to the home only, and it is the responsibility of the male uh, gender to take care of this, to take care of the health, take care of the health of the females, and use and generate data through research to facilitate a more nuanced understanding of the gender-based health issues. Because if we have proper data, then it will help us in focusing the target areas where we all need to take care of the female health. So the top 10 issues for women health as outlined by WHO are, number one is the cancer. And we have got three leading speakers from different cancer institute who will be elaborating on cancer, which is related to the females. So two of the most common cancers affecting the women are the breast and the cervical cancer. And detecting both these cancers early is the key, keeping women alive and healthy. The latest global figures show that around 500,000 women, they die from cervical cancer, and 500,000 of the females, they die from the breast cancer each year. The vast majority of these deaths, they occur in low and middle income countries where screening, prevention and treatment are almost non-existent, or where vaccination against human papilloma virus needs to take hold. So cancer screening, awareness about cancer in women, that we have to further enhance, so that the cancer can be prevented. And if it is there, then it should be diagnosed in early stage when it is almost curable if properly taken care of. Then comes the reproductive health. The sexual and the reproductive health problems are responsible for 1/3 of the health issues of the women between 15 to 44 years of age. Unsafe sex is a major risk factor, particularly among women and girls in developing countries. And this is why it is important to get services to 222 million women who are not getting the contraceptive services which are required and they need. Then comes the maternal health. Many women are now benefiting from massive improvement in the care during pregnancy and childbirth, which has been introduced in the last century. And but those benefits do not extend everywhere. And in 2013, more than 3 lakh women died from the complication in pregnancy and childbirth. These are WHO figures. And most of these deaths could have been prevented, and access to the family planning and some quite basic services if they had been there in place. Then comes the HIV infection. As we all know, that 3 decades into the AIDS epidemic, it is young women who bear the brunt of the new HIV infections. And too many young women, they still struggle to protect themselves against the sexual transmission of HIV and to get the treatment where it is required. And this also leaves them particularly vulnerable to tuberculosis, which is one of the leading causes of death in low income countries of women from 20 to 59 years of age. Then comes the sexually transmitted infections, which we all need to focus on. That I've already mentioned the importance of protecting against HIV and the human papilloma virus, which are the most common sexually transmitted diseases. But it is also vital to do a better job of preventing and treating disease like gonorrhea, chlamydia, syphilis, which are quite prevalent among the females. Untreated syphilis is responsible for more than 2 lakh stillbirths and early fetal deaths every year, and for deaths over 90,000 newborns every year. Violence against the women, that also need to be taken care of, because women can subject to a range of different form of violence, from physical and sexual violence, either by partner or someone else. Today, 1 in 3 women under 50 have experienced physical or sexual violence by a partner or non-partner sexual violence. It is important for health workers to be alert to these violence, so they can help them to prevent it, as well as provide support to people who experience it, because it leads to a lot of physical and mental torture to the females. So it is very important for the for maintaining and further increasing the women health. Now, after and during this COVID pandemic, mental health, it is now in focus, more in focus, because evidence suggests that women are more prone than men in experiencing anxiety, depression, and somatic complaints, especially the physical symptoms that cannot be explained medically. And depression is one of the most common mental health problems for women and suicide, a leading cause of death for women under 60. So mental health of female is very important, and it is vital to help and sensitize women towards the mental health issues and give them the confidence to seek assistance. Then comes the non-communicable diseases, which everyone need to focus upon. In addition to cancer, now heart disease, respiratory disease, all these diseases, they are very common. And in 2012, 4.7 million women, they died from non-communicable disease before they reached the age of 70. And they died as a result of maybe road traffic accident, harmful use of tobacco, use of alcohol, drugs, and substance abuse, and obesity. And in Europe and America, more than 50% of women are overweight. And overweight is one of the leading cause of breast cancer in obese females, because obesity, that fat is the source of the estrogen hormones, and ER/PR positive breast cancers, they are more sensitive to these hormones from the fat tissue of the postmenopausal females. So obesity is of concern. Helping girls and women adopt healthier lifestyle early is a key to health, long and healthy life. When the females are young, adolescent girls, they face a number of sexual and reproductive health challenges, like sexually transmitted diseases, HIV, pregnancy. So that need to be taken care of. And complications from pregnancies, childbirth, they also need to be taken care of for those young mothers. And many of them, they suffer the consequences of unsafe abortion. So these are the things which we all need to take care when they are young. And when they are in old age, having often worked in the home, older women, they have fewer pensions, financial benefits are less, and they have less access to the healthcare and social services than their male counterparts. So in that case, the combined and greater risk of poverty with other conditions of old age like dementia, then osteoporosis, older women also have a high risk of abuse and generally poor health. Cancer is also one of the leading cause of mortality and morbidity in older age group. So we have to take care of these health issues in older females. So the priorities for women and health as per WHO is address gender inequality in the COVID-19 response and recovery. We have to provide health care facilities to all the females, and there should not be any gender inequality, and elevate the position of the women in the health and care workforce. Now, as we are seeing in healthcare sector, more and more female, they are coming, and we have to elevate their position, and we have to give them proper guidance, respect, and proper position, so that they can further increase awareness about the health of the female workers across the globe. Then prevent and respond to the violence against the women. A lot of now these acts are there which prevent and take care of the these women's abuse, and ensure quality sexual and productive health for all, reduce non-communicable disease among the women, and increase women's participation and leadership in science and public health. So in this way, these are the concerns which I thought I should share with you all, in addition to the cancer and the non-communicable diseases, reproductive health, mental health, all these issues, if they are taken care of, especially during their early life, when they are young, during their reproductive life, and even when they are elderly. So if they are taken care of properly, then a healthy female can definitely take care of their family, the society, the community, and they can play a great role in keeping our society healthy. So with this, I thank you all very much for giving this opportunity to me to share my concerns. And all these issues, they are being deliberated across the globe. And we in India, we also need to focus on these issues. And you all onco physicians, onco surgeons, you all are taking care of preventing malignancies in females, and raising awareness about the cancers, female cancers, and especially early detection, screening. So all these things are important. And from association side also, we are all taking care of all these issues. And for last 2 years, I think most of the, many, not most, many of the webinars, they were on the cancer related issues only.
Absolutely.
And in addition to prevention screening, we were talking about what are the latest treatment which are available, and how it can be extended to the community, because now these immunotherapies, targeted therapies, they are quite costly, and they are not equally distributed amongst the deserving lot. So we all need to together work towards achieving these goals. And with this, thank you very much, Dr. Pawan, and all the learned speakers.
Thank you so much, sir, for sharing your thoughts, perspectives, and inputs. I think very well stated in a very comprehensible manner. Mental health, definitely non-communicable disease. Yes, we females, generally, you rightly mentioned that these are at times ignored, at times just left like that, and that's the reason probably that after even close to 75 years of independence, we have like close to 50% of the females who are still suffering from anemia. A basic simple thing, but we have not been able to eliminate it. We have not been able to control it. Just give an example. Apart from the things that you have just mentioned, Dr. Sharma, gender inequality, yes, non-communicable diseases, definitely, and then mental health, and then sexual health, reproductive health. We definitely need to look keenly on it and contribute maximum we can. Thank you so much for sparing your time and for sharing these thoughts. This is going, this very loud message, loud and clear, and concern is really, really genuine. With that, I move to the next aspect of this webinar. And before that, I just like to mention to all panelists and attendees, please keep posting your questions and queries in the chat box or the Q&A box, and you can directly send it to Secretariat so that our learned speakers can take them up in the appearance of in the order of their appearance. Also, you can raise your hand once the session is over so that we can take the questions. I would like to hand over this e-platform to Dr. Varun Goel, who is one of the speakers of the evening on breast cancer screening and diagnosis, and also he will be moderating the entire session from here. Dr. Goel is the consultant medical oncology, Rajiv Gandhi Cancer Institute and Research Center, Delhi, and we are privileged to have him with us today evening. Over to you, Dr. Goel, for further deliberation and moderation of the session. Thank you so much.
Thank you, Dr. Pawan, and thank you, Dr. Sandeep. Very informative and relevant talk. And you have touched upon all the burning issues. Obviously, we usually talk about the cancer only. That is also a very important talk. But those are the relevant issues we should discuss about that also. So with that, so we will switch the gear, and we will now discuss about the oncology aspect. So my dear colleague, Dr. Shiv Shankar, he just had requested me if he can prepone his session, like he has some urgent work after that. So I will talk later. Dr. Shiv Shankar will talk first. So he is my dear friend and colleague, consultant in Rajiv Gandhi Cancer Hospital, Medical Oncology Department, and he will talk about the management of ovarian cancer. So over to you, Shiv Shankar.
Thank you, Varun sir, for those kind words. I'll share my slides.
Visible. Dr. Swami, yes.
Yes. Good evening, everyone. At the outset, I'd like to thank the organizer for providing this wonderful opportunity to discuss one of the another important burning issue that women of our country facing. It is the third most common cancer among females in India. So let's take a look at how the management and how this ovarian cancer presents, how the management has changed over last few decades. So we'll be discussing briefly what are the epidemiology and risk factors related to ovarian cancer. Then we will look at what are the various types of ovarian cancer, then common presentation of ovarian cancer, and finally we'll be discussing upon what are the recent trends in the management of ovarian cancers. So first, looking at the epidemiology of ovarian cancer, if you look at the in the global population, the ovarian cancer stands around the 7th most common cancer across the globe. It roughly constitutes to roughly around 3.4%. That is 295,000 patients will be diagnosed with ovarian cancer each year across the globe. So if you look at the scenario in India, it is the third most common cancer among females in India. So it constitutes roughly around 6% of the cancers among females being diagnosed with cancer in each year. So this translates into 36,000 patients will be diagnosed with ovarian cancer every year in India. So looking at the various risk factors, one of the important risk factors for ovarian cancer is history of ovarian cancer in the family member. If any of their first degree relative have a ovarian cancer, it increases the risk of having a ovarian cancer. Apart from that, another important is the number of ovulation cycle the woman undergoes, that also linked to the ovarian cancer. Higher the number of menstrual cycles, then more the risk of ovarian cancer. So what are the things which are associated with increased number of menstrual cycle? Either if they are early menstruation, initiation of menstrual cycle early in the age, or late menopause, or fewer pregnancies. Pregnancies will reduce the number of menstrual cycle. If there are more number of menstrual cycles, again, it will increase the risk of ovarian cancers. Apart from that, we have something called as a genetic predisposition. One of the common genetic predisposition is BRCA genes. Apart from that, if any of the genes which are involved in homologous recombination defect, all these genes can also contribute to development of ovarian cancers. Apart from this, lifestyle factors like obesity can also predispose to ovarian cancer. So ovarian cancer rates are highest among women aged between 55 to 64 years. It is very common. It is less common among less than 45 years. Usually, if they have a genetic predisposition, they do develop under the age of 45 years. So looking at the various types of ovarian cancers, ovarian cancer is not a single entity. It is a heterogeneous group of diseases. Ovarian cancer means any cancer which arises in the ovary. So in ovary, what are the types of cells we have? We have epithelial cells, we have stromal cells which supports the epithelial cells, and we also have a germ cells. So depending upon from what cell it arises, it is divided into three broad categories. Epithelial tumors, which constitutes roughly around 90% of the cancers. Today's talk will be mainly on the epithelial tumors, and another two small group of tumors are stromal cell tumors, which constitutes 5%. They are either granulosa cell or cytolytic cells, or germ cell tumors, which again constitutes for another 5% of ovarian cancers. They are like teratoma, desgerminoma. They are usually common in younger females. So today's talk is mainly on the epithelial ovarian cancer, which constitutes to 90% of the ovarian cancers. Among these ovarian cancers, again, it is further divided into different types based upon the histology. The most common epithelial ovarian cancer being the high-grade serous ovarian carcinoma, which constitutes roughly around 70%, followed by clear cell endometrioid, low-grade serous, and mucinous carcinoma. The treatment patterns, prognosis all differs depending upon the type of histology. So again, if you look at further, if you go deep into this high-grade serous ovarian cancer, again, it is not a single entity. It is, if you look at the molecular structure of this ovarian high-grade serous ovarian cancer, again, we will get a pie chart, something like this. Some may be harboring a BRCA germline mutation, some may be having a somatic BRCA mutations, some may be having another mutations in HR pathway like CDK12, RAD51C, Fanconi anemia genes. Any of these in other molecular abnormality may be P10 pathway or cyclin E1 or mismatch repair or nucleotide excision repair mutations. These can be in that way. So if you look at these molecular structures, some may be harboring BRCA or some may be harboring different. So they also behave differently, they also respond differently, and they also they have a different prognosis. So looking at the clinical presentation of ovarian cancers, one of the biggest problem with any malignancy, and also it applies to the ovarian cancer, is they do not have a very specific symptoms. They present with a vague symptoms. It is quite common to have most of these females who are having a menopause to have these kind of problems like vague abdominal pain, constipation at this old age. Constipation is a common problem. Fatigue is a common problem. Urinary frequency is a common problem in this age group. So often this is neglected as some benign problem, and this often leads to late diagnosis of ovarian cancers. So usually majority of our patients present in an advanced stage, that is increased abdominal girth, that is abdominal distension, bloating, loss of appetite, dyspepsia, respiratory symptoms, or abdominal mass. So what are some of the how do we, once we suspect ovarian cancer, if somebody presents with these complaints, how do we investigate these patients? After detailed history and evaluation of risk factors, we do go ahead with a physical examination. Basically, physical examination will provide things about whether patient has ascites or any mass palpable per abdomen. After that, usually we move with the ultrasonography followed by imaging, and certain tumor markers like CA-125 is very helpful in the diagnosis and management surveillance of these ovarian cancer patients. So if we have, like for breast cancer, we have a very good screening program. So do we have a similarly screening program for ovarian cancer? No, there is no recommended screening for CA ovary, because none of these tests have shown any benefit in a randomized controlled trial fashion. But transvaginal ultrasound and CA-125 can be used as a screening methods, particularly in those who have a high risk of developing CA ovary, particularly those who harbor genetic mutations, which we discussed previously. So once ovarian cancer is suspected, then we need a confirmation to that matter. For any malignancy, we need to confirm with the histopathology. Similarly, we need a confirmation in ovarian cancer. If it is upfront operable, then we directly go with a laparoscopy or laparotomy for diagnosis of ovarian cancer. If it is not upfront operable, then probably image guided biopsy will yield the histopathological sample for confirmation of different type of ovarian cancer. So once we confirm it is a ovarian cancer, that is as epithelial ovarian cancer, then we have something called as a FIGO or TNM staging to classify these patients. So accordingly, treatment protocols will differ depending upon the stage of ovarian cancers. So we have 4 FIGO stages, stage 1 to stage 4. Stage 1, if you look at it, is cancer which is limited to ovary. Again, in stage 1, it is stage 1A to 1C, depending upon single ovary or 2 ovaries, or both the ovaries are involved, or if there are a surface involvement. If it is stage 2, it is beyond ovary, but it is limited to the pelvis. Stage 3, it is beyond pelvis, it has already involved the abdomen. Stage 4, not only the abdominal lining, it also involves abdominal structures like maybe liver is involved or the lungs have involved, then it becomes a stage 4 ovarian cancer. So very important topic, that is BRCA genes, which is one of the predisposing risk factors for ovarian cancer. This also not only has a risk factor involvement, it also predicts treatment options in ovarian cancers. So this is about the one is the prognostic implication and also predictive, whether a platinum group of drugs works better. Definitely they works better in the BRCA mutated patients, and also role of PARP inhibitors is very clear in BRCA mutated patients. So whom do we test for BRCA mutations? BRCA mutations, previously we need to look for those patients who may have a higher incidence of BRCA mutations, something like those who have a familial history, those who develop ovarian cancer at early stage. In those patients, we used to advise BRCA mutation. But now with the availability of treatment options based on BRCA mutation, all the patients who are diagnosed with a high-grade serous ovarian cancer should undergo BRCA mutations. And what type of BRCA mutations? It may be tumor BRCA mutations because it does not require genetic counseling and it can be added at first clinical meeting itself. Otherwise, for genetic risk assessment, we need a germline BRCA mutation, which require a proper pre-genetic counseling and at least 1 month gap prior to initiation of this germline BRCA test. So this is how we order. If it is for predictive, for treatment option purposes, tumor BRCA alone will suffice. But if it is for risk assessment of the family members as well as the patient of developing other cancers apart from ovarian cancer, we also need a germline BRCA testing. So this we usually follow NCCM guidelines, that is guidelines from US, which provides a management and surveillance guidelines across various malignancies. This is how NCCM guidelines for ovarian cancer looks. So depending upon the stage, either they can go for if it is an early stage, stage 1A, B, still fertility preservation surgery is possible. If it is beyond that, or if fertility is not desired, in such cases, usually hysterectomy and bilateral salpingo-oophorectomy followed by chemotherapy is the preferred option. So again, if you look at only in stage 1 or B, low grade serous ovarian cancer, mucinous ovarian cancer, we can observe. Otherwise, if it is a high grade serous ovarian cancer, we usually, after surgery, we usually go for a chemotherapy. Stage 1C, usually stage 3 and 4 beyond, we can also use bevacizumab. Though in the study settings, they used even in the high risk early stage ovarian cancers. So if they are not amenable for upfront surgery, usually we go for a cytoreductive surgery upfront. If not amenable, then they can be planned for neoadjuvant chemotherapy followed by cytoreductive surgery. So that is in the first line management, we usually have surgery plus chemotherapy. If it recurs, then again we define the treatment options based on the timeline of recurrence. Usually majority 70% of the women do recur. One of the bad thing about this ovarian cancer is majority of the patients do recur, though they respond excellently with first line of therapy. 70% recur within 3 years, and depending upon the timeline with recurrence, whether they recur within 6 months, it is labeled as platinum sensitive. If they recur 6 months to 12 months, it is platinum. Within 6 months, it is platinum. If they recur within 6 months, it is platinum resistant. If they recur after 6 months, then it is platinum sensitive. But however, in the recent guidelines, they tend to say that there is a lot of differences in how do we diagnose. Earlier days, it was a symptomatic diagnosis. Now with the availability of sensitive imaging, these definitions are a bit blurred. Nowadays, they use the term platinum eligible or platinum non-eligible recurrences. So once they usually in the stage 3, stage 4 ovarian cancer, the long-term survival is very small, that is to the tune of 15%. However, with the advent of newer therapies like bevacizumab and PARP inhibitors, things have started to improve the outlook of ovarian cancer patients. So this is how the timeline of evolution of management of ovarian cancers. Way back before 3 decades, hardly we had few drugs. From last 2 decades, we can see that there are a approval of many drugs in the management of ovarian cancer, improving the outlook of this group of patients. So once they progress in the first line of the management, usually, I mean, in the last decade, in the first decade of this century, the chemotherapy remained the first treatment, only the treatment option in the management of ovarian cancer. However, in the beginning of the second decade, there was a approval for bevacizumab. Later, we also got a approval for PARP inhibitors, which has dramatically changed the outlook of these patients. So today's talk mainly emphasizing on the newer recent trends in the management of ovarian cancer, that is olaparib. Olaparib has been approved at various indications in the management of ovarian cancer as a maintenance therapy and also as a single modality of therapy. But recently, single modality of therapy has been withdrawn, and nowadays it is widely used in the management of maintenance as a maintenance treatment in ovarian cancer. So where can we use as a maintenance therapy? Either following a first-line therapy, the evidence for the olaparib maintenance is SOLO-1 trial, or following a platinum-sensitive recurrence. If they had a platinum-sensitive recurrence, if they had a recurrence following it after 6 months, and if they respond to the second-line therapy, then again olaparib maintenance can be given in the second-line setting. So in the first-line setting, we have a two trial. One is SOLO-1 trial in the BRCA mutated patient. It may be tumor BRCA mutated or germline BRCA mutated, or we have a PAOLA-1 trial, which looked at olaparib maintenance in the first-line trial. If they have, apart from BRCA mutation, if they had a mutation in another HRD pathway. So all HRD positive patients are eligible for this olaparib maintenance along with bevacizumab. So to look at these trials, the first trial we had was a SOLO-1 trial. This is a randomized phase 3 trial, which randomized stage 3-4 ovarian cancer patients into olaparib versus placebo. So the primary endpoint was PFS. The secondary endpoint was OS, PFS2, and health-related quality of life. So very rarely we get to see such a huge magnitude of benefit and such a huge separation of Kaplan-Meier curve. If you look at the curves are well separated quite early in the timeline, and they kept on, I mean, the separation is even at the 5 years timeline. It is almost to the tune of 27%. So it is very rare to see such separation of curves in the management of malignancies. So one such is with the olaparib. So if you look at the median PFS, it has improved from 13 months to 56 months, means from 1 year to almost 5 years if the patient is put on olaparib in BRCA mutated patients following first line treatment of ovarian cancer patients. So the side effects with ovarian olaparib, any drugs comes with the toxicity. Similarly, the toxicity is commonly seen with PARP inhibitors is GI toxicities, nausea, fatigue, vomiting, and hematological toxicities like neutropenia and anemia. So another important trial, apart from those who do not harbor BRCA mutation, is for them is a PAOLA-1 trial. It not only included BRCA mutated patient, it included all comers of ovarian cancer. So in this trial, if you look at, it has definitely shown improvement in the progression-free survival compared to placebo when olaparib was added to the bevacizumab. Across all groups, whether they are younger than 65 or PIGO stage 3, stage 4, irrespective of that, it tend to favor olaparib arm. So if you look at this population, there were all kinds of population. There were tumor BRCA mutated, germline BRCA mutated, HRD positive, HRD negative, HRD unknown. All kinds of patients which we see in real world setting were present in this study. If you look at the outcome by subgroup, in intent to treat population, the magnitude of benefit was only to the tune of 5 months. But however, among those who had HRD positive or tumor BRCA mutated, among them the magnitude of benefit was huge, with hazard ratio of 0.31, means 70% reduction in having a PFS event. So again, similar curve to the SOLO-1, huge separation of curves and early separation of curves. This is in HRD positive but non-tumor BRCA mutated, which was not answered in the SOLO-1 trial. Again, there is an improvement in PFS from 16 months to 28 months with an improvement of 12 months for patients who were put on olaparib apart from bevacizumab. So in overall population, the magnitude of benefit was very small to the tune of 4 months. So it did not get approval in the entirety of population. Only in the HRD positive population, it got approval to use as a maintenance therapy in first line management. So again, if you look at the side effects different compared to bevacizumab, it was almost similar except for GI toxicities. So other rare side effects of olaparib are something like hematological toxicities like MDS, rarely seen in less than 1% of patients, liver secondary malignancies, pneumonitis. These are dreaded complications, but are very small in number. So clinical decision making depends upon various factors, depending upon the affordability of patients, logistics, toxicity profile, and also looking at the efficacy and what patient desires. Based on that, the treatment decisions are usually made. So to conclude my talk, among women, ovarian cancer is the 8th most common type of cancer worldwide and 7th most common cancer for mortality in the across the globe. If you look at the India, it is 3rd most common cancer among females in India. Among the ovarian cancers, epithelial cancers predominates. Among epithelial, high-grade ovarian cancer, high-grade serous carcinoma is the most prevalent cancer. Diagnosis of ovarian cancer is often delayed because of non-specific symptoms. If ovarian cancer is suspected, patient will undergo diagnostic evaluation, including history, physical examination, imaging, and with tumor markers with a CA-125. Evaluation undertaken following previous, and also it includes if amenable for upfront surgery, they go for upfront surgery. If not, biopsy followed by neoadjuvant chemotherapy. With the availability of newer modality of therapies like PARP inhibitors, the outlook of these patients has significantly improved. Despite this, the majority of patients do recur. With this, I conclude my talk. If there are any questions, we can discuss. Thank you.
So this was a wonderful presentation, and thank you, Dr. Shiv Shankar. Just once. Yes. So you have touched upon all the important aspects of the on management of ovarian cancer very well, and you have already talked about the latest advances in that, and like it was a very informative and lucid and crisp presentation, and I think that will be beneficial for the audience also to understand the overall management of the ovarian cancer. So if any query, any question from the audience side, they can unmute yourself and can ask with my dear colleague, and otherwise we will discuss at the time of panel discussion.
Thank you, sir.
So next we will discuss about the management, screening and diagnosis of breast cancer. That talk I will take personally. So I'm going to discuss this topic in following headings. And so initially we will discuss how and from when this breast cancer has been there in the history books, and what is the current stats, what is the overall incidence and prevalence and mortality due to this cancer worldwide. And then we will talk about the classification and molecular classification, and about the diagnosis and treatment plan guidelines. And so to begin with, if we see history-wise, so in 1600 BC, it was the first mention of this breast cancer. There are 8 cases of tumor or ulcer in the breast had been described. Then later in 548 AD, first mastectomy was performed. 1700, French surgeon Louis Petit have removed breast tissue with lymph node and underlying chest muscle. Later in 1926, first breast cancer clinical study was conducted. In 1930s, breast cancer staging system were developed. Then 1945, around 60 years back, it was the year then when modern chemotherapy was developed. It was after World War II. Then radiation therapy generally adopted as a treatment of choice, treatment of method in 1950s. And in the last three decades, in 1990s, Susan Lev have published the first breast book, which was the huge source information for the entire generation population of women that time. In 1992, it was the year when pink ribbon was adopted as an official symbol for the National Breast Cancer Awareness Month. In 2002, Women's Health Initiative trial conclusively proved that HRT have significantly increased the incidence of breast cancer, and we should avoid wherever possible use of HRT for a longer time. In 2008, the White House is decorated pink for the first time in honor to National Breast Cancer Awareness Month, which we usually celebrate in the month of October every year. Coming to incidence of the breast cancer. So in this geographical distribution map, we can clearly see that breast cancer is more common in developed countries like European countries and America and Australia. So, but nowadays, its incidence is increasing very rapidly in developing countries like India also. On the other hand, if we see mortality wise in the world map, then in developed countries, mortality is higher than a developing country, where incidence is lesser, but mortality is higher. So mortality is higher in African and South American and these Asian countries. So there is high unmet need to address for the management of these breast cancer patients to reduce this mortality rate. So first of all, what is the breast cancer? For my audience who are or are not doctors, so they should know that any cancer is a uncontrolled division of the abnormal cells, which is uninhibited and going on to divide without any growth factor. So similarly, in the breast cancer, these abnormal breast cancer cells divide uncontrolledly, and there may be different types of breast cancer. To begin with, it may be invasive or in situ. Then later in further slides, I'm going to discuss what are the different histological subtypes, molecular subtypes, how we grade these cancers, and how we stage these cancers. So is there any difference in these terms, invasive and in situ? Yes, in situ is, we may say, pre-cancerous state. So here DCIS and intraductal are the numerology, and these are pre-invasive. So in AGCC staging, these comes into stage 0. And what is meaning of pre-invasive or non-invasive? They have not invaded basement membrane of the cells till now. So they have not any capacity to spread. While invasive cancers are infiltrative to the surrounding normal tissues. So according to AGCC staging system, they can be staged into 1 to 4. 1, 2 is localized, 3 is usually if lymph node metastasis, regional lymph node metastasis have been there, and 4 is distant mets are there. So they have invaded basement membrane, and in the view of that, they can assess blood vessels and lymph vessels, and they can go on to metastasize to the systemic tissues. So histologically, they are mainly of 2 types: ductal carcinoma breast and lobular carcinoma. So ductal is more common one. 80 to 85% of the breast cancer are ductal one. 10 to 15% are lobular one. Molecularly, or I may say IC wise, we should divide all these breast cancer patients, and we can divide into these molecular subtypes: luminal A, B, HER2 positive, and basal light, because all breast cancers are not similar, and there is they are highly variable according to these markers, and if we can provide treatment accordingly, they act as prognostic markers also. So in luminal A, ER and PR are positive, HER2 is negative, but there is Ki index is low. In other words, multiplication and mitosis rate is low. In luminal B, similar ER and PR positive, HER2 positive, or otherwise maybe HER2 negative, but Ki index 67 index is high. In HER2 positive breast cancer, only HER2 is positive, API negative, basal like all are negative. In other terms, sometimes we may refer these cancers as TNBC, triple negative breast cancers, although they are not vice versa. There are some differences. So that is beyond the scope of documentation. Coming to grade and stage. So grade is which our pathologist state that what are the cancer cells look like under the microscope, and depends on the degree of differentiation, and we may divide overall breast cancer cells into well differentiated, moderate differentiated, and poorly differentiated types. And stage according to AGCC, which depends on tumor size, lymph node status, and distant mets. Anatomically, it has prognostic value also. So if tumor size is less than 2 centimeter, that is T1, 2 to 5 T2, more than 5 centimeter T3, and inflammatory invasive cancer to the skin overlying, it is T4. So according to these T and M status, overall staging from 1 to 4, normally patients have been divided into these stages, and these stages have significant prognostic value. What are the symptoms of breast cancer? So obviously patient usually present with the lump in the breast, which because of the lack of awareness, mainly in the rural areas, patient may, because of some hassles or non-availability of the proper proper medical facilities. So they may go on to just without addressing that, and that lump may convert into disease, and then later may metastasize. Beside that, patient may complain of pain and overlying skin redness, itchiness, nipple distortion. There may be discharge of blood bleeding from the nipple, and otherwise, if patient if disease already have gone to systemic spread, then patient may present with weight loss and back pain and abdominal pain and other symptoms. What are the risk factors why this breast cancer develops? So there are some risk factors which we can modify, like exogenous hormones, as I've stated earlier, that with prolonged use of hormone replacement therapy, it has been reported that that is a main risk factor of the breast cancer at that time. Otherwise, nullipara or females who had not breastfed their child is the risk factor for development of breast cancer. Prolonged alcohol use, obese women, if previously because of any other reason high dose radiation have been given to the chest, that is also a risk factor to the breast cancer development. Other risk factors which are non-modifiable, which are you can't change that, and that is gender. Obviously, females are more prone to development of breast cancer if you compare with the males. Then age, increasing age is more risk for development of breast cancer. Some genetics, and these are very important nowadays. We should look for if any genetic mutation like HRR or BRCA mutation is there, to go, if by that we can go for family screening also, as Dr. Shivashankar also have stated, to test HRR in ovarian cancer also. So these are the risk factors. So if we see out of all, how many of the breast cancers are hereditary, where we can found some gene alteration and which we can go for family screening and other issues. So out of all, around 20 to 25% patients are associated with the significant family history or some hereditary gene association. So what are the breast cancer susceptibility genes? So there are tumor suppressor genes like P53, P10. They have high penetrance, low frequency predisposition gene. Some are like ATM, PALB2, CHEK2 are moderate penetration with low frequency predisposition genes, and low penetration and high frequency predisposition genes include others. So how these genes convert normal cells to breast cancer. So this is I may say beyond our today's discussion, but still overall just to just as a discussion part. So there are some tumor suppressor genes which usually suppress the tumor, but mutation on that those can develop into the tumor. There are some cell proliferation of growth factor receptor genes. So if any mutation in those, they can then cell can go on into proliferation phase forever. Other genes like cell cycle regulation, hormone metabolism, and DNA repair genes also act significantly in the mechanism of development of the breast cancer. Out of all genes, most important one and most targetable one, for which we have drugs available, are BRCA1 and 2. So these genes have been reported in up to 30 to 40% of the females if we do testing in all. So this we have already discussed. Now coming to next part. So we have seen how breast cancer develop, what is the pathophysiology, what is the epidemiology, what is the risk factors, staging, and types of the tumor. So but main part is how we should go ahead for the screening, so that like we can diagnose these cancers at an early stage so that we can go ahead with the curative intent. So as such, for the screening purpose, from the age of 40 years in general population, we should educate the females to do self breast examination once in maybe 6 months, clinical breast examination once in a year, then mammography once in a year. It may be X-ray mammography or ultrasound or MRI mammography depending on patient age and denseness of the breast. And in some females, MRI mammography required. This is BIRAT scoring on the this is scoring system for mammography reporting. So in this, if up to 3, that is normal, and if 4, then it is suspicion, and we should do either Efficacy biopsy for those lesions if BIRAT 4 lesions are there in the at the time of screening radiography. And then if 5 or 6, then almost confirmed that this is breast cancer. How we should do biopsy for these tumors, these lesions, if they are BIRAT 4. So for establishing a diagnosis, whether cancer or not, or if something is there, whether that is invasive or in situ or type of tumor and other receptors like ERPR, HER2, we have to do biopsy. So sometimes it is a big question in almost every patient mind that if you can skip biopsy because they think that with biopsy tumor may spread. So just to emphasize here that without biopsy, we can't get to know about the type of tumor, about the receptors, about the molecular classification and the prognosis and predictive value of those receptors. So we have to do biopsy before starting the treatment of these breast cancer patients. So for getting these, we have to do FNAC or core-needle biopsy. And in some patients where single small lesion is there, we can go ahead with a excision biopsy. Then these are genomic, some light on the genomic test and prognostic staging. So there are different tests like Oncotype DX, MammaPrint, EndoPredict, PAM50, and breast cancer index, which we usually do after surgery or excision biopsy or MRM or BCS. If we have want to see whether those females will get any benefit from the adjuvant post-surgery chemotherapy or just hormone therapy are sufficient, especially those tumors in which ERP are positive, HER2 negative, and up to T1 or 2, but lymph node and distant match should not be there. So how breast cancer spreads? So obviously it goes by the flow, like from breast tissue usually goes to axillary lymph nodes, that is called regional disease, and then go on to systemic organs like bones, lung, liver, brain, and other tissues, that is distant disease, and that accounted as stage 4 disease. So it is almost 99% patients spread occurs like this, but it is not 100%. In some patients, there may be spread which direct systemic spread may be there without axillary lymph node spread. So where comes the role of medical oncology? Obviously, as an adjuvant treatment, that is post-surgical treatment. If local disease is there and if those tests shows that there is high chances of recurrence, then in those patients we should offer adjuvant chemotherapy. In few local disease but not upfront surgically resectable, we have to give chemotherapy before surgery. In stage 4, obviously chemotherapy is the backbone of the treatment. Beside that, according to the different molecular classification, we may go ahead with the targeted therapy or some immunotherapy, biological therapy, or hormone therapy. So this is to further emphasize that if patient is of luminal A or B, usually they are ERPR positive, HER2 may be there or not. So these patients are usually treated with the hormonal agents, with or without targeted agents like palbociclib or ribociclib. And if HER2 rich or basal type tumor, then chemotherapy to be given in those patients with some HER2 directed therapies and some novel therapies which are under research. So these I already discussed. We have options of neoadjuvant therapy, adjuvant therapy, and palliative chemotherapy for the metastatic disease. So these are also beyond today's discussion. This just to emphasize that out of all, TNBC are the worst prognosis, and HER2 positive disease also have poorer prognosis if we can't target that with HER2 directed therapies. So there are different types of HER2 directed therapies, including trastuzumab, pertuzumab, TDM1, lapatinib in the oral form, and nowadays GDX also available. In chemotherapy, there are different agents, out of which most common and most important ones are anthracycline and taxanes. Beside that, we have other types of chemotherapy, including methotrexate, 5-FU, gemcitabine, platinum agents, capecitabine, vincristine, these or vinorelbine. These all are important ones, and we can give these chemotherapy one by one on progression if required. Coming to these International Breast Cancer Treatment Guidelines. So there are different associations like National Comprehensive Cancer Network Guidelines, American Society of Clinical Oncology Guidelines, and ABC Guidelines, Esmo Guidelines. All these have strategized how and when we should give treatment, which treatment. There are different permutation combination where we can give chemotherapy, single agent, doublet, with or without target therapy, or all. So we usually follow these guidelines to treat our patients, and so that there should be uniformity of the treatment of these patients, and there should be good results for the response wise. So these guidelines are widely used international guidelines. These recommend endocrine therapy for the preferred first-line treatment option for the HER2 positive, hormone receptor positive, HER2 negative advanced breast cancer. Endocrine therapies are administered sequentially, either or as a single agent or in combination. With the availability of targeted therapies nowadays, for, I have named already, palbociclib or ribociclib, and some mTOR inhibitors, these can be combined with endocrine therapy. And with this, I end my presentation, and house is open for any query. If any query, you can ask, and otherwise we will discuss in the last. If no question further, I want to invite my dear friend, Dr. Shekhar, for the next talk, which will be on role of IV iron for the management of iron deficiency anemia, overall in females, and especially in these patients who have already suffered from the cancers. So we have seen that in these cancer patients, especially gynecological malignancy patients, including cervical cancer, many times these patients suffer with the anemia, and many times we focus on the chemotherapy and target therapy or immunotherapy part, and we don't see about this management of anemia. Many times we just give blood transfusion, but that is not the answer of this question. We should evaluate further just to see what is the reason, and then we should treat accordingly. And most common reason in Indian females, most common reason of anemia is iron deficiency. And so for that, next talk is about that, iron deficiency anemia, and how we can treat that. So over to you, Dr. Shekhar.
Good evening to all of you, my respected seniors and teachers. Am I audible?
Yes, you are audible.
So I am going to present briefly about the cancer-related anemia. A lengthy presentation, but I will try to finish it as early as possible. So
your voice is slightly lower side. So if you can first, please like change your slide into presentation mode, and please, if you can, slightly louder.
Slide is visible, sir?
Yes, slides are visible. So please go ahead. Yes.
So the cancer-related anemia is a important problem in our line of in our medical oncology department. around 75% of patients deal with this problem, mainly the hematological and both hematological and solid tumors associated with these problems. And in our country, it is especially an important burden in view of the prevalence of malnutrition. So in this slide, you can see the iron deficiency is associated with anemia in various types of cancer, including the hematological and solid tumors. The causes of cancer in causes of anemia in cancer, these are nutritional, related to hemolysis. This may be due to blood loss or infiltration of the bone marrow by the tumor cells or myelosuppression. And the consequences of this alarming condition leads to fatigue, poor pH. It will hamper the quality of life. It will leads to aggravation of the existing comorbidities that ultimately can lead to premature death. So this is the anemia scale. We can grade anemia according to this: mild, moderate, severe, or life-threatening. In case of mild, it is lower limit of normal to 10. For moderate, less than 10 to up to 8. For severe, it is less than 8 to up to 6.5. And for life-threatening condition, it is less than 6.5. So we already know almost all of the chemotherapeutic agents can lead to anemia. And most of these agents leads to grade 1 and grade 2 anemia mainly. But if we see, there are certain chemotherapeutic agents or the regimens that leads to grade 3, even grade 4 anemia, like CHOP regimen. It leads to 17% chance of developing grade 3, grade 4 anemia, like cisplatin etoposide combination in case of various type of small cell cancers. So who are at risk for developing this cancer related anemia? So those patients who are older aged, their baseline hemoglobin is already in the lower limit, planned for myelosuppressive chemotherapeutic agents, and those patients who are already in transfusion, who are already in transfusion dependent, and those patients who receive radiation therapy for more than 20% of wounds. So baseline investigation, we should do a CBC, retic count, peripheral smear, and some other investigation that include stool for occult blood, iron profiles, B12 folate level, serum creatinine. We should calculate the patient's GFR. We should do for a direct or indirect Coombs test or serum heptoglobulin. So based upon this investigation, we can categorize the cause of anemia. It may be due to iron deficiency. It may be due to some hemolysis related. It may be due to some other deficiency related. So for iron deficiency, hemoglobin, ferritin, and transferrin saturation all will be in lower side. So what will be the goal to treat this patient? So our goal will be to improve the HB levels, to improve the quality of life, and to reduce the need for RBC transfusion. Other than that, with the treatment of iron therapy or infusion therapy or blood transfusion, we can actually improve the outcome of oncological treatment in those cancer patients. So how to approach to an anemia in a cancer patient? As per the NCCM guideline, as I am already discussed, we should go for retic count, CBC. We should rule out the cause of hemorrhage. To rule out this, we should go for a stool occult blood or endoscopy testing. To rule out hemolysis, we should do a direct Coombs test or LDH level, or we should go for indirect bilirubin level. To rule out nutritional deficiency of anemia, we should do iron profile, B12 level, or folate level. To rule out inherited cause, we should evaluate, we should take the family history or past history of any transfusion, etc. Now, in whom we should consider for transfusion. So to remember, any patient, any cancer patient having anemia, and the anemia is symptomatic. Symptomatic means symptomatic tachycardia, tachypnea, chest pain, dyspnea on exertion, syncope, etc. If these are symptom is there, we should transfuse with blood. And the second second thing is that if a cancer patient is having anemia but asymptomatic, but those patients, if having any cardiac disease, any lung disease, or any other comorbidities, we should treat with transfusion. So this is the two things we should remember. So what are the benefits and risk for transfusion? Benefits are rapid increase in Hb level, rapid symptomatic control, and it avoids the risk of erythropoietin stimulating agents use. And the risks are, it increases the thrombotic events, it increases the risk of transfusion related infection, it increases the risk of congestive heart failure, bacterial infection, iron overload. So there are multiple options. We can transfuse blood, we can give iron injection. So whom to give iron injection? So as per the Nccm guidelines, first we will do baseline investigation. After the baseline investigation, if we found that the patient is having absolute iron deficiency, that defines as ferritin level of less than 30 or transferrin saturation is less than 20%. Those patients we should consider for IV or oral therapy. And the other category is functional iron deficiency, that is anemia of chronic disease, defined as ferritin level 30 to 500 along with saturation level is less than 50%. In these two categories, we can use IV iron. So we already know there are multiple preparations available in market. So which preparation we should use? So I will go in details further in later slides. Now coming to the Esmo guidelines. As per the Esmo guidelines, they have categorized the anemia in cancer patient into three groups: less than 7, those patients with hemoglobin less than 7, 8 to 10, or more than 10. So patient came with less than 7. So first thing we should evaluate whether there is rapid need of correction of this hemoglobin or not. If there is rapid need, we should transfuse. If not, then we will further evaluate the cause of anemia. So to rule out or to diagnose the cause, we will do B12 folate as already described. So as per the report, if there is B12 deficiency or folate deficiency, we'll go to treat according to that. If it is diagnosed as absolute iron deficiency, we'll give directly IV iron, followed by ESA agents. Now the patient is diagnosed as functional iron deficiency, that is anemia of chronic disease. So in that case, we'll start treatment with IV iron along with ESAs. But if the patient is having no iron deficiency, only having anemia, then we'll start with ESA agents. So what are the options for treatment in iron deficiency? These are we can advise dietary modification, oral iron therapy, IV or IM iron therapy, or blood transfusion. So oral iron therapy, very easy, very cheap, and but the problem is that it takes time to improve the blood levels. It can cause gastritis, nausea, diarrhea, faintness, dark stool, or constipation. So this is the article that published the oral versus IV iron replacement therapy, the effect of these two therapy in IBD patient. So they have found that those patients who are having IBD and took oral therapy, in that case there is alteration in the gut flora, and that leads to exacerbation of the chronic ileal inflammation. So in that case, it is better to avoid oral therapy. So coming to the parenteral therapy, these are the various types of parenteral therapy with their distinct color. These are the available IV preparation: first generation, second generation, and third generation. Mainly we'll discuss today about the ferric carboxymentos. So it has two parts: the inner iron hydroxide core and a outer ferric carboxymaltose part. The most important thing of this carboxymaltose is its stability. So in the change of any pH, it remains stable. So this is the main part that differentiates this preparation from the other preparation. So how does it act? So ferric carboxymaltose after transfusion is taken up by the reticuloendothelial system within times. So after taken up by the reticuloendothelial cells, the iron is delivered to the iron binding proteins, that is ferritin or transferrin. Now the transferrin, what transferrin do is that transferrin takes the 80% iron to the marrow and 20% of the iron remains in the reticuloendothelial cell. The efficacy of ferric carboxymaltose you can see in this slide. With a single cycle of ferric carboxymaltose infusion, and after a 6 weeks of gap, we can get more than 1 gram of improvement in hemoglobin level. That is significant. And this is the efficacy of ferric carboxymaltose in different type of anemia. In iron deficiency anemia, but no anemia, mild, moderate, or severe. So here we can also see in each type it is effective, but the effect is quite high in case of moderate to severe anemia. Comparing the ferric carboxymaltose with oral iron therapy, the response rate after 3 weeks is better with the IV iron therapy, and after 6 weeks it is 100%. So the response rate is 100% with IV therapy. So IV iron therapy is more effective, better tolerated, and it is important to give this IV preparation to those with excessive bleeding, early requirement of improvement of HB, GI intolerant patient, those patients can't take oral preparation, or those patients having impaired absorption, or those patients with irritable bowel disease. So comparing the second versus third generation IV preparation, the slide we can see the response rate or the effectiveness is better with the third generation ferric carboxymaltose as compared to iron sucrose. After a period, and it starts from 2 weeks, and it continues its effectiveness beyond 2 weeks. So what are the adverse effects of IV iron in IBD patients? So previously I have already described that oral iron therapy can lead to exacerbation of IBD symptoms, but various trials have shown that IV iron doesn't have any effect on IBD patient. So the advantages, it is effective, rapidity, the response rate is quite good, and it starts within weeks, relatively free from any adverse event, no test dose is required, no GI intolerance with the IV therapy. Other advantages, it can be given within minutes, at least 15 minutes is required. It is cost effective, and the most important thing, it avoids the need of frequent blood transfusion. So the indication of this ferric carboxymaltose third generation IV preparation, intolerance to iron therapy, oral iron therapy, inadequate response with oral iron therapy. The definition of inadequate iron response is less than 1 gram improvement with 4 weeks of oral treatment. So, and the other indications are need for a rapid response, postpartum anemia, menorrhagia, IBD, cardiorenal syndrome, and those patients with CKD, we should give IV iron along with ESS. So coming to the dose is different when we give as a bolus injection and when we give as a intravenous injection. In case of bolus injection, we should give 200 mg per day, and we should repeat 3 times in a week, not more than 3 times. For IV preparation, we can give maximum dose of 1 gram of IV iron and should repeat only after 1 week. Now calculating the requirement of iron dose. So this is the formula: 0.3 into body weight into Hb deficit. Hb deficit is the target minus the latest Hb. So if a patient is having weight of 100 pounds and Hb of 6 gram, this will be his requirement. But here I can add something that we should add extra 500 mg along with this requirement. That will replenish and make added iron to the iron storage. To a simplified scheme to remember, patient is having mild anemia, with a body weight of less than 70, we should give 1 gram. And if the body weight is more than 70, we should give 1.5 gram. For moderate, 1.5 or 2 gram. And for severe anemia, we should give 2 gram for the less than 70 kilo body weight patient and 2.5 gram for overweight patient. But remember, in each week, we should give maximum of 1 gram of IV iron. So how should we administer this IV iron preparation? So when we give as IV bolus, we should give as a undiluted slow intravenous push with the preparation should be made by 500 mg dose in 10 ml, and the rate will be 100 mg per minute. The risk of extravasation is quite there with the IV iron preparation. So if there is any extravasation or any discoloration, we should discontinue the treatment from that side, and we can change to other side. Now, when we administer as IV infusion, the preparation will be 500 mg iron with a maximum of 250 ml of normal saline. And the speed will be, and the duration of infusion should be minimum of 15 minutes, at least 15 minutes. So again, no more than 15 mg per kg in one sitting, maximum of 1 gram. Minimum 15 minutes of time to be taken for IV infusion, and we should not re-infuse within a week, and the second dose should be given after a week. The tolerance is quite good, as various published data shows the tolerance is quite good with IV iron as compared to the oral iron. Now this is a publication that was presented that after starting iron gluconate, the mouse liver shows necrotic changes on a microscopy. But in case of ferric carboxymentos, there is no necrosis, though the human studies is not there. So the side effect or toxicity profile for this IV iron therapies, you can see the ferric carboxymaltose and iron dextran are quite safe as compared to the iron sucrose or ferric gluconate, that is first and second generation. Adverse event, yes, there are some adverse event related with this IV iron preparation, mainly the hypersensitivity reaction. Second most common is hypophosphatemia, quite common with this. Third is hypertension, and other are nausea, flushing, or dizziness. So there are multiple references that has shown effectiveness of IV iron therapy over oral therapy in treating cancer patient. So this is a publication that shows that IV iron administration in cancer patient leads to better quality of life, early recovery of anemia, and it also helps in recovering from the disease itself, and it also has an effect on overall survival. Another publication that also described that IV iron therapy stabilizes the hemoglobin in between 11 to 12 quite effectively in very short period of time. This is another article that also described that it is quite effective and it leads to improve the quality of life along with OS benefits. Again, another publication describing the same things with IV iron preparation. So this is the side effect profile with oral iron and IV iron, specifically the ferric carboxymaltose. So we can see the most important side effect with IV iron preparation is decreased in serum potassium, headache, and infusion related reaction. So treating a anemia patient in cancer, if rapid correction is required, option will be Taxol, IV iron, followed by other therapy like ESS or oral preparation. So depending upon the requirement, depending upon the comorbidities, we should choose accordingly. And then if we start any IV iron preparation, we should start with the third generation and specifically the iron carboxymentos based upon the various published trial that shows it has an OS benefits in cancer patient and it helps in recovery of the disease itself. Thank you.
So thank you, Dr. Shekhar. So it was a wonderful presentation, and we have obviously discussed about all the aspects, why this is important, what is the epidemiology of this problem, and how we can address that. For that, with this now last part of the session today, so I will invite Dr. Kumardeep Datta sir. So he is a senior consultant and unit head in Action Cancer Hospital. So we all know him. There is no need to any introduction. So over to you, Dr. Kumardeep sir.
Thank you, Dr. Varun. So
Yes,
basically, I've been assigned to do moderate a session on today's evening, and
so mainly, sir, just if like we can ask from our like attendees and panelists some issues regarding the management of and mainly screening and diagnosis of these cancers, mainly gynecological cancers, or some important point if you just comment upon.
So basically, Dr. Varun, actually, I am thinking about another important aspect.
Yes, sir.
Of because I have seen of late in last 2 days 3 cases of HCC, and those who had the patient had a chronic hepatitis B virus infections, and ultimately that had led to development of HCC. So, what is your take on the preventive aspect of any cancer, or in gynecological cancer in particular? Are we counseling our patients or the patient attendants who are coming with attending our patients about this preventive aspect of different types of cancer?
Sir, obviously very pertinent question and a very important point. So as I discussed earlier, that many times what happens when patient comes to us, we just narrow down our discussion to that patient. We should discuss about the family members and other relatives and all, how we can prevent these cancers to be happen in the family. So as you have asked about the preventive measures, obviously we first of all about the vaccination. So we have option of HPV vaccine in mainly for female and males, but obviously for males also. So in Western countries, it is very common to give HPV vaccination for those mainly teenage group to all the males and females. But here, that practice is not so prevalent. So, so argument for that, we usually say that in our society, there is no like practice of like polygamy and sexual intercourse before marriage and all. But this is not the case. We should offer this HPV vaccination for every females, and mainly because it has been clearly documented that this HPV vaccination can prevent cervical cancer. Beside that, HPV vaccine, as you have told, that you have seen some SCC patients which are HPV positive. Obviously, this is a most common etiology of SCC. But nowadays, obviously, NASH is increasing in incidence wise as a etiological factor, but still. So HPV vaccine should be given, and now even according to government policy, HPV vaccine has been incorporated in their policy, vaccination policy, and have been included to be given in all the newborns and then at regular interval. But at our generation, that HPV vaccination was not so common. So many times HPV infection happens as a chronic infection, and then may develop into CRD and SCC. But at least to our patients, we can offer them, they can go ahead with the HPV titer testing, and if that is not there, if they have not infected till yet and have not get vaccine, they can go ahead with the HPV vaccination at least. Beside that, no other vaccine have been clearly incorporated as a prevention for cancer. But yes, we have to, we should do genetic counseling and genetic testing, especially in the BRCA associated syndromic cancer, especially breast cancer and ovarian cancer, to check for families, to go ahead for family screening, and if there are any mutation in the normal person, so that we can go for early screening in those patients, in those persons, mainly in females. So this is my take. Any other point or any other comment from your side?
Dr. Shiv Shankar, is he here? Dr. Shiva?
Sir, I'm here, sir.
Yeah, Dr. Shiva. Actually, I just wanted to clarify because Dr. Varun has touched upon that factor of BRCA-related testing and family history of cancers in ovarian cancer. As we are discussing about gynecological cancer, we'll limit our discussion to the gynecological cancer only. So what is your take on HRD testing versus vis-a-vis BRCA1, BRCA2 only in CO ovary? What do you advise to your patients?
Sir, exactly, it depends upon the what is our intent of testing, sir. If it is for the management purpose, if it is for treatment purpose, if patient is affordable for olaparib, definitely I'd like to go for HRD, not just BRCA alone. If it is only for screening purpose, if it is patient is not affordable for olaparib, and if it is only for screening of the family or screening for other cancers, then definitely I'll just limit to germline BRCA mutation, sir.
Right, right. So your first approach is the patient had no financial constraint.
Yes, sir.
So how do you proceed for those patients?
If patient has a no financial constraints, for germline BRCA mutations, the first issue is we need a pre-genetic counseling and 1 month waiting period. For HRD, we do not have any such issues. So, and also it is freely available. AstraZeneca is sponsoring HRD as a free. So usually we go ahead with HRD testing, sir. So if it also gives whether patient has a BRCA mutation or not in that HRD testing. If in the HRD positivity, if it is only BRCA mutation, then we will only those patients will go for germline BRCA testing.
Right. And what about cervical cancer screening? What is your take on cervical cancer screening?
Sir, cervical cancer screening, it should be, it is one of the common malignancy in India. So definitely it should be practiced. Cervical cancer screening should be practiced among all the females who are aged more than 30 years. And if they are less than 30 years, at least for screening for HPV DNA should be incorporated.
Right. And so, suppose your patient is coming up with BRCA positive,
Yes, sir.
germline BRCA positive. How do you follow them up? Say a CA breast patient who is coming up with a BRCA positive, germline BRCA positive, and how do you screen for the ovarian cancer?
Sir, for ovarian cancer, usually first what we see is what is the BRCA type of mutation, whether it is a BRCA1 or BRCA2, and second, whether they have completed their family or not. If they have completed for their family, and if then we will advise them to go for risk reduction salpingo-oophorectomy, sir. If they have not completed family and they are desiring fertility, in those situations, usually we advise the screening protocols such as 3-monthly ultrasonography, USG abdomen, or transvaginal ultrasonography if there is any suspicious thing, along with CA-125 protocols. So though there is no support such screening tool, the best we have for those populations who desire for fertility preservation, who desire to have their ovary intact, for them these are the like something like Roma. These are the probable screening tools. Hello, sir.
Yeah.
Yes.
My next question is like,
Just to add
any
the last
particular-
question.
Yeah,
So just to add to the last question. So issue is like we say that for patient point of view, we should go ahead with the somatic, and for family point of view, we should go ahead for germline. But why so? We should do both now. Like in any case, if we don't do germline testing, we just focus on some patient. Then later, if any family member develop cancer, he may ask us that why don't we have do germline testing that time? What about that? Like I think in any case, in every patient, we should go ahead with the both testing.
There is another point I just wanted to ask both of you, like risk reduction salpingo-oophorectomy has been done, and now you want to, what is your instruction for the pathologist?
Or pathologist?
Yeah, any particular instruction you want to give, any information or anything you particularly want to know about that, or any instruction, anything other than normal findings, whatever we write on our histopathological specimens, anything other than the normal.
Sir, in histopathological specimen, basically we would like to look for any stick in the fallopian tube, because majority of these high-grade serious ovarian cancer, they arise in the fallopian tube rather than the ovary itself. So to look for stick.
Yeah. That is the particular, especially at the fimbrial end of the fallopian tube. These are the most common sites of
Yes, sir.
high-grade tumors. So they should look fimbrial, and more section should be done on the fimbrial end. So that is the catch. So I think we have discussed most of the part in time clinical relevant questions. So any question from the audience is also welcome if there is any query.
If no question further, then I think we may close today's session. So is Dr. Sandeep is there? Dr. Sandeep?
I am very much there.
Yes. So first of all, I want to thank Dr. Kumardeep sir for a wonderful discussion. And these are 2-3 points only, but these are very relevant and very important point to discuss. So over to you, Dr. Sandeep, for your comment. Any?
Yeah. Thank you, Dr. Varun. Actually, this whole discussion was quite relevant in context with the health of the female workers. And why I'm saying workers, because we are mainly dealing with the workforce who are working in the industry. So, but it involves the whole community, female community, and a lot of screening initiatives they need to be undertaken by the doctors, oncologists, even the general physicians, in care for early diagnosis of the cases, and for to spread awareness about the cancers amongst the females. So this cancer screening, like in breast cancer, BRCA, and other screening, people are aware of that, but how to go about it, that is more difficult for them to understand, because these tests are very costly. And second thing, if someone develops, then who all they need to be taken care of, and they should go for all these sort of genetic studies so that they can be taken care of in future. And regarding this vaccination part is very important. So whosoever we think that it is necessary for them to get vaccinated to prevent cancer, that is very much required. Maybe cervical cancer or HPV vaccination. So all these vaccinations, they are very important. Screening is important. Vaccination is important. Early diagnosis and awareness, all these things, they are very important. And lastly, the treatment part. What is the exact treatment which is required for that particular stage of the disease? That is also very important, and we should spread awareness that amongst the masses, that if they are diagnosed early in early stages, then it is almost cured. And if it is diagnosed in late stages also, now the therapies are available which can take care of these advanced stages, but they are quite costly and they need to be taken like target therapies. They have to be taken lifelong. So all these things, awareness, if we spread amongst the masses, then people will definitely come forward and get themselves screened and get themselves vaccinated, and early detection of the female cancers. And whatever points I had told in my earlier this presentation, that in addition to cancer, there are many factors which need to be taken care of in case of females. And so we have health. Healthcare, it should be comprehensive for the females. It should include cancer. It should include other non-communicable disease, communicable disease, infections. Then there other social aspects also we have to take care. So a great session. A lot of insight was there in today's session. So thank you very much for organizing this, and especially on our platform. And this was live recorded, and it will be available on our DigiConnect webinar platform. And we can see that after a few days, a lot of views will be there regarding this particular session.
So thank you, Dr. Sanjeev. Thank you arranging this and inviting us for this webinar. And obviously we enjoyed a lot for discussing this and like for spreading awareness about these female cancers. So thank you once again, all the panelists for joining today, and attendees also for sparing time for patients listening. So thank you once again, Environment and Occupational Health Initiative Organization. And thank you all the sponsors for this today's meeting, including my pharma companies. And so thank you once again, and good night, everyone. Good night.
Okay.